Sir, we are live now. With all your permission, I'm starting this session.
Yes.
Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome our speaker with great honor, none other than Dr. Vikram Londe, sir. Sir is Associate Professor of Medicine and in charge of Rheumatology at HBT Medical College and Dr. R.N. Cooper Hospital, Juhu, Mumbai. Consultant Rheumatologist, Critical Care Hospital, Mumbai, Vice President of Maharashtra Rheumatology Association, Associate Editor of JAPI. Today, sir is going to discuss on a topic, rheumatoid arthritis. Let me tell you overview of the topic. Rheumatoid arthritis, that is RA, is a chronic autoimmune disease that primarily affects the joint, causing inflammation, pain, and progressive damage. It is characterized by immune system mistakenly attacking the body tissue, particularly the synovial lining of the joints. RA is commonly affect the hands, wrist, feet, and knee, but can also involve other organ and system in the body. To know more about this topic, I would like to invite sir and hand over this session to sir. Sir, over to you. Kindly proceed from here.
Yeah, good evening.
Sir, yeah, continue, sir.
Yeah, so today we'll be discussing about rheumatoid arthritis. Now, RA is the most common inflammatory joint disease which is seen in clinical practice, affecting approximately 1% of the total population. It is a chronic multisystem disease. The exact cause is not yet known. It is characterized by persistent inflammatory synovitis, which leads to cartilage damage, bone erosions, joint deformity, and disability if not diagnosed in time and not treated in time. Genetically predisposed individuals who have a specific 5 amino acid sequence in the hypervariable region of HLA-DR4 is susceptible for the development of rheumatoid arthritis. Another protein which has been identified is the protein tyrosine phosphatase 22 and PADI4. When the person is having these two proteins, he or she is at increased risk of developing rheumatoid arthritis. It is also very common in the family that if a family member is suffering from RA, then the next generation is likely to suffer from RA. Cigarette smoking increases the risk. Now, any disease gets triggered by a certain infection. Same is true for rheumatoid. A bacterial or a viral infection triggers the chronicity of this process and it triggers the immune system. In the environmental stimuli, the exposure to cigarette smoke, exposure to viral antigens will increase the susceptibility. Now, when we consider the sex ratio, male is to female is 1:2 or 1:3. And we see most commonly females in the reproductive age group who present with this disease. It can also be seen in elderly patients above the age of 60 years. And when they present for the first time above 60, we call it as late onset rheumatoid arthritis. So what is the difference between the early presentation and the late presentation? The late presentation is more likely to be progressing faster, it is aggressive, and it causes erosions very rapidly. As far as the pathogenesis is concerned, the innate immunity causes activation of the fibroblasts like synoviocytes and the dendritic cells and macrophages. This causes a chronic inflammation which leads to citrullation of the proteins. The dendritic cells will migrate to the central lymphoid organs to present these antigens, and once the antigen presenting cells have presented these antigens, they will activate the T cells. Now, what do these activated T cells do? They activate the B cells in turn, which will produce the rheumatoid factor. The lymphocytes will migrate back to the synovium and there is release of inflammatory cytokines. As a result of ongoing inflammation and ongoing inflammatory cytokines which are released, they will cause synovial proliferation and pannus formation. So if we look at this picture, you see that the T cell and the antigen presenting cell will present the antigens to the macrophage. The macrophage gets activated. which leads to chronic inflammation by the release of various inflammatory cytokines like interleukin-1, interleukin-6, tumor necrosis factor alpha, and the whole cascade of inflammation sets in. As a result of which there is proliferation of the synovial membrane, the chondrocytes get activated, and there is deposition of fibroblasts in the synovial membrane as well as in the cartilage, which gradually gets eroded, as a result of which the acute process progresses to the chronicity. The basic pathogenetic identification on histopathology is the pannus formation, which is nothing but proliferation of the synovial membrane along with erosions of the cartilage cells. There is production of matrix metalloproteases and other effector molecules which cause migration of the polymorphonuclear cells at the synovial membrane as well as at the cartilage site, and that causes cartilage and bony erosions. So if the disease is not diagnosed for a long time, this process of pathogenesis will progress the patient to chronic disability as well as chronic erosions, where the patient would present late in the course of the disease with joint deformities. And therefore, the whole idea of knowing the pathogenesis is to attack the pathogenesis at an earlier stage, thereby the patient does not progress to erosions and does not develop deformities. So when there is an imbalance in the cytokines, the pro-inflammatory cytokines are more as compared to the anti-inflammatory cytokines will tilt in favor of development of inflammatory cascade, which will progress to the development of pannus, and that will cause the erosion. So the main pro-inflammatory cytokines are interleukin-1, tumor necrosis factor alpha, interleukin-6, which are very, very important as far as rheumatoid is concerned. So what are the symptoms that the patient will present with? Joint pains along with restriction of the movements of joints. The joint pains are so severe that the patient may not be able to move the fingers because it involves the small joints of the hands, the metacarpophalangeal joints, the proximal interphalangeal joints, the wrist joints are the most common ones which are affected in rheumatoid. Along with that, the large joints like the knees, the ankles, and the hips can also get involved. So there has to be a symmetrical involvement. Joints are involved simultaneously in both the hands, both the feet. There has to be a significant morning stiffness, which should be lasting for more than 45 minutes to 1 hour or even more than that. If the morning stiffness is for less than 10 to 15 minutes, it is not considered to be significant, and you have to think of other diagnosis other than rheumatoid arthritis. There is small joint involvement as well, which is a prototype which is seen in rheumatoid arthritis. The patient may complain of low-grade fever or may just complain of a feverish sensation, fatigue, and sometimes there may be history of weight loss because of the inflammation. The patient starts eating less. On examination, when you check for the joints, you will have to passively give pressure on the small joints as well as the large joints, and there is presence of squeeze tenderness. So when you passively give pressure over the joints, the patient will complain of tenderness of that joint. There will be restriction of movements. When you passively try to flex or extend the wrist or passively try to flex and extend the knee, there may be restriction along with pain. Same thing is possible in the elbows, and it can be possible in the shoulders or the hip joints. Now, when the patient presents late in the course of the disease, they will present with different types of deformities. The swan neck deformity, the boutonniere deformity, and the Z deformity, which are commonly seen in the hands, and the hallux valgus deformity, which is seen in the feet. Now, what are the various articular manifestations? If we see this skeletal diagram, it is showing the temporomandibular joint, the medial end of the clavicle, the shoulder joint, the elbow, the wrist, the small joints of the hands involving the metacarpophalangeal joints, the interphalangeal joints, the knees, the ankles, and the small joints of the feet. Pain, which is affected by aggravation of the joint movement, will be the common symptom. Morning stiffness will be present for more than 1 hour, and these are the joints which are inward. So the patient will tell you that if it is a female who is working in the kitchen, she will not be able to put her hand in the dough and mix the dough properly. She will not be able to open the tap or close the tap. She will not be able to open the latch of the house because you require small joints for all these movements. There may be difficulty in standing up, there may be difficulty in walking when the disease is active. So these are some of the pictures which show that there are deformities of the hand. You can see that there is Boutonniere's deformity in the picture A. There is swan neck deformity along with the Z deformity in picture B. If you do the X-rays, you can see multiple erosions in the head of the ulnar. You can see erosions in the carpal bones, and the lowermost picture is showing the ultrasound of the joint, which shows presence of inflammatory fluid along the tendon sheath and the joints. So these red signals which are marked with the arrow are showing active inflammation in the joint. So when you do an ultrasound of the joint and you see the Doppler studies, it will all show red when it is inflamed. So this X-ray which is showing erosions tells us that the disease has been going on for quite some time, that the patient has already presented with erosions. These are the hands which are seen in rheumatoid. You can see in the middle finger and the ring finger of both the hands that there is swan neck deformity, there is flexion at the distal interphalangeal joint and hyperextension at the proximal interphalangeal joint. Whereas in the little finger of both the hands, you can see the reverse type of deformity, which is called as Boutonniere's deformity. You can see flexion at the interphalangeal joint and hyperextension at the distal interphalangeal joint. The proximal one is showing flexion, the distal one is showing hyperextension. These are the hallux valgus deformity of the feet. Now there are certain extra-articular manifestations. Beyond the joint, you may get the features. So the A photograph is showing synovitis and rheumatoid nodules along the elbow of the person. The B picture is showing rheumatoid nodules along the insertion of the tendo achillis. The C picture is showing uveitis, and the D picture is showing uveitis along with thinning of the cornea. So as the disease advances, there may be corneal melting and the patient may lose vision. So what are the investigations that you should know of when you are suspecting a patient to be suffering from rheumatoid arthritis? A CBC will tell you how much is the hemoglobin, the WBC count, the platelet count, the erythrocyte sedimentation rate, and the C-reactive protein will tell you about the active inflammation which is ongoing in the patient's body. Rheumatoid factor and anti-CCP antibodies should be checked in patients suspected with rheumatoid arthritis. Now, although these antibodies are checked and whether they come positive or negative, the diagnosis of rheumatoid arthritis is mainly clinical. So you may get a patient who is rheumatoid factor positive but does not have any joint pain. You may have a patient who is anti-CCP positive but does not have any joint pain. So what is the interpretation of these tests? You can observe the patient closely for a period of next 2 years. If at all he or she develops the joint pains with swelling, with tenderness, with restriction, that would be the time when you will label the patient as rheumatoid arthritis. Rheumatoid factor can be false positive in elderly patients. It can be false positive with hepatitis B infection, HIV, and it can be false positive in 10% of the normal individuals in the society. So interpreting rheumatoid factor should be done with caution. It does not mean that rheumatoid factor positivity is equivalent to a patient suffering from rheumatoid arthritis. Now, anti-CCP antibody is an antibody which is more specific for rheumatoid as compared to the rheumatoid factor. The baseline liver function test should be done because when you're going to use medications like NSAIDs and methotrexate, you need to have the baseline liver function test. Baseline renal function test with a GFR should also be monitored at least once in a year. X-ray of both hands with wrist and X-ray both feet depending on which joints are affected. Fundoscopy to monitor the foveal reflex because the patient is going to be on hydroxychloroquine and hydroxychloroquine can cause damage to the macula. So once in a year fundoscopy or once in 5 years. So how do you decide when to do fundoscopy? If the patient is asymptomatic, you can do it once at the baseline and after 5 years. If the patient complains of decreased vision or any visual complaints, then you may refer to the ophthalmologist and get a fundoscopy every 1 yearly. Now, counseling is very important to the patient because they need long-term medications. What is the need to take medications? If they don't take, they are going to land up with deformities. They have to monitor the blood parameters every 3 monthly to know that the side effects of medications are not occurring. These females are in the reproductive age group. If they are planning pregnancy, certain medications like methotrexate, leflunomide have to be avoided. Safe medications during pregnancy would be steroids and hydroxychloroquine, azathioprine, sulfasalazine. Unsafe medicines during pregnancy would be methotrexate and leflunomide, and therefore contraceptive advice should be given to these patients when they are suffering from RA and have yet to complete the family. The medicines will consist of disease-modifying anti-rheumatic drugs or biologic response modifiers. Physiotherapy and occupational therapy is equally important to keep the patients moving, and ophthalmology reference to monitor the foveal reflex. So what are the diagnostic criteria for rheumatoid arthritis? Morning stiffness for more than 1 hour, arthritis of more than 3 joints, including the small joints of the hands, feet, arthritis of the hand joints, mainly the PIP and metaphalangeal and wrist joint, symmetrical arthritis, presence of rheumatoid nodules, positive rheumatoid factor, and radiographic erosions. Now, this seventh criteria, we don't want to wait up to the erosions. So these are the American College of Rheumatology criteria of 1987. So the patient should fulfill criteria 1 to 4 for more than 6 weeks and must have more than 4 criteria to meet the diagnosis of rheumatoid. So newer classification criteria, which came in 2010, have got a joint involvement, the serology, acute phase reactants, and the duration of symptoms. Depending on that, the score is given from 0 to 5 for the joint involvement, 0 to 3 for the serology, your rheumatoid factor positivity or negativity, low titer rheumatoid factor, high titer rheumatoid factor, ANCA antibody, anti-CCP antibody, positivity or negativity, normal CRP or elevated CRP, normal ESR or elevated ESR, all these are given various points. And when you add the total number of points, a score of more than 6 by 10 is needed for classifying the patient as definite rheumatoid arthritis. Now, the problem here is sometimes when the large joint gets involved in osteoarthritis, the patient may get a score of 1, whereas the serology may not give you any score. So the duration of symptom and the small joints have been given more weightage. How do you treat a patient of RA? The goals of management should be focused on relieving the pain, preventing damage and disability, patient education about the disease, physiotherapy and occupational therapy. You may require stretching and range of movement exercises, splints and adaptive devices for walking, for keeping the patient mobile, and treatment should be started early and should be individualized. Each patient may not have the same prescription. Early aggressive treatment is recommended for majority of the patients. So when patient is having low disease activity, you start DMARD monotherapy. Most of the time it is methotrexate or hydroxychloroquine or leflunomide, depending upon the clinical presentation. You can wait for a period of 3 months before adding the second drug, or depending on the symptoms or the disease activity. If the patient presents with a high disease activity, you can start with triple therapy like methotrexate, hydroxychloroquine along with leflunomide, or you can start methotrexate, hydroxychloroquine combination along with steroids and NSAIDs for initial 6 to 8 weeks. You may consider adding TNF alpha blockers, or you may consider abatacept, or now the newer drug which is available is the JAK2 inhibitor, tofacitinib, which can be added upfront when the diagnosis of rheumatoid is made, or you can add it subsequently at the end of 3 months if there is no response to methotrexate. So this is the algorithm to treat RA to target. You need to achieve the patient into remission, and once the remission is achieved, meaning the patient becomes symptom free and is not complaining of any active pain, tenderness, restriction of movements, and the remission which is achieved should be maintained in the long run. So that is a sustained remission. These are the treatment modalities. You treat with NSAIDs. You can use indomethacin, etoricoxib. You can use diclofenac, naproxen. Individual patient may require individual type of NSAID. A person responding to diclofenac need not necessarily mean that the second patient will also respond to diclofenac. He may require etoricoxib. Now, what is the role of steroids? In the initial 6 to 8 weeks, when the inflammation is severe, you don't want the patient to progress to erosions. Your DMARDs are going to take time to act, about 6 to 8 weeks, and that is the time when you need to treat the patient with steroids after adequate counseling. Steroids can be given orally, intravenously, or intrathecally. There are biological therapies which are available if the DMARDs do not achieve a proper remission, or biological therapies may be given as a first drug of choice depending on what is the case scenario of the patient. Patients who present late in the course of the disease may require knee replacement surgery or hip replacement surgery. There are hand surgeons also available in the city of Mumbai and other metropolitan cities, where hand surgeries can also be done for deformities. Now let us quickly see what are the limitations of DMARDs. The onset of action takes several months. The remission induced in many cases may be partial. There is substantial toxicity which requires careful monitoring. The DMARDs may have a tendency to lose effectiveness as the time passes. So these drawbacks made the alternative treatment strategies like the biologic response modifiers. So when to start the biologics? When there is inadequate response to methotrexate or a combination of other synthetic DMARDs. You can add either tocilizumab, or you can add infliximab, etanercept, adalimumab, golimumab, or abatacept and rituximab. So these are the biologics that are available. The TNF alpha inhibitors like adalimumab, golimumab, certolizumab, infliximab, and etanercept. Interleukin-1 receptor inhibitor like anakinra, interleukin-6 inhibitor tocilizumab, anti-CD20 antibody rituximab, and T cell co-stimulation inhibitor like abatacept. Of these, now abatacept and anakinra are not very easily available, and certolizumab also is not very easily available. So we have the options between adalimumab, golimumab, infliximab, and etanercept. The TNF blockers will block the immune system that cause the inflammation. In healthy individuals, excess TNF is blocked naturally, but those who have conditions like rheumatoid will have higher levels of TNF that lead to joint inflammation, destruction of the joint, and persistence of symptoms. So the anti-TNF agents target an inflammation-causing substance called TNF, that is tumor necrosis factor alpha. Now, before starting the patient on biologics, you need to rule out active tuberculosis, CBC, baseline, LFT, RFT, rule out HIV status, hepatitis B status, hepatitis C status, and the ESR CRP. The patient should not be in class 4 cardiac failure. These are the various TNF blockers like infliximab given as infusion to be given on day 0 after 2 weeks and after 6 weeks, and a maintenance dose every 8 weeks. Etanercept can be given 25 milligrams subcutaneously twice a week. Adalimumab 40 milligrams subcutaneously every 15 days. Anakinra not available in India, so we'll not discuss it. It is very difficult to procure it. Abatacept was earlier available, but now the production has been stopped. Rituximab available in the dose of 1 gram, which is given on day 0 after 2 weeks and 24 weeks. And tocilizumab 4 to 8 milligram per kilogram IV monthly can be given. So don't let rheumatoid arthritis distort the picture. Therefore, beat the disease, detect it early, treat it early, and save the patient from developing deformities. Thank you.
Yeah, thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. Sir, I can see, sir, we have received some question from the participant doctors. If you allow, can I take this question with all your
Yeah,
permission?
sure. Yeah.
I can see, sir, the first question from Dr. Agarwal. He is asking, is joint aspiration useful in diagnosis of RA?
Joint aspiration is mainly to exclude that there is no infection in the joint, there is no hemarthrosis. It does not have any diagnostic value in diagnosing RA. In fact, if the patient is having pain in a single joint, joint aspiration becomes helpful to relieve the pain, and simultaneously you can inject intra-articular injection of steroid. So once you want to know that it is only inflammation and not infection, there you have the role of joint aspiration. Otherwise, joint aspiration does not have a role in the diagnosis. The diagnosis is mainly clinical. Only to exclude infection from the joint, you may do the joint aspiration.
Okay, thank you so much, sir, for answering this question. I hope that Dr. Agarwal has received his answer. I can see another question is from Dr. Anubhav Jaiswal. He's asking, what is the role of T cell in pathogenesis of RA?
Yeah, the T cell, the antigen presenting cell, will go to the macrophage, and the macrophage will be a connecting link between the innate immune system. So the macrophage will present the antigens to the T cell, and the T cell will get activated. The T cell in turn will act as a co-stimulator, and it will activate the B cells. So the T cells has got a dual role. It will accept the antigen presenting cell in the form of macrophages, and it will present this to the B cell, thereby the production of antibodies will take place. That is your rheumatoid factor.
Okay, thank you so much, sir, for answering all the questions, sir. As I can see, there is no more questions from the participant, but there is one feedback from Dr. Shweta. She has written wonderful presentation. Thank you so much for discussing on this topic. And Dr. Shweta is having a feedback, sir. I hope that she has really enjoyed this session, sir. I hope that all the doubts of the doctors related to this topic has been clear, sir. As there is no more questions, sir, if you allow, can I conclude this session with all your permission?
Thank you. You can conclude.
Okay, thank you so much, sir, for giving your valuable time once again, sir. And hope to see you again with different topic in coming time.